Imagine this scenario. It's a chaotic night in the emergency room. The fluorescent lights are humming, the monitors are beeping, and then the doors just burst open. Paramedics wheel in a 20-year-old woman. She's been caught in the crossfire of a street shootout. She is in shock. Her skin is pale, clammy, her pulse is thready and rapid, and her blood pressure is just crashing.
It's a high-stakes, absolutely terrifying situation. The trauma team swarms in, and they immediately spot the entry wound. It's small, maybe a centimeter wide, right in the fourth intercostal space on the left side, just next to the sternum.
And no exit wound.
No exit wound. That's the scary part.
The left side of her chest sounds dull when they tap on it. There were no breath sounds. She is bleeding out internally. The attending physician knows there was absolutely no time for a CT scan.
None.
They have to go in. They have to perform an immediate thoracotomy right there in the trauma bay.
And this is the moment where anatomy stops being a textbook subject and becomes a map for survival. To save this woman's life, that physician has to cut through layers of skin, fat, fascia, and muscle to reach the heart.
But here's the catch.
Yeah, the catch is it's a minefield. If they cut just a few millimeters in the wrong direction, they could slice the internal thoracic artery or sever a vital nerve, turning a rescue mission into a tragedy.
It's so intense. And it really makes you wonder, how do they know exactly where to cut? I mean, how do they navigate those layers without causing more damage?
The answer lies in understanding the map of the thoracic wall.
You have to know the territory.
Exactly.
Welcome to the Deep Dive. Today we are opening up the chapter on the thorax from Snell's Clinical Anatomy. And specifically, we are looking at the thoracic wall.
Right.
Now, I know what some of you might be thinking. Anatomy. Is this going to be a dry list of Latin names?
We are definitely not doing that, no. We are here to interpret the text. We want to take those dense anatomical facts from Snell's and turn them into a mental map, a cheat sheet, if you will, for you.
So whether you're a medical student, a nurse, or just someone who is insanely curious about how their body is built.
This is for you.
But reading is becoming a lost art. We are giving you the audio tour, but we really, really want you to go back and look at the map yourself. Use this deep dive to spark that curiosity, to open the actual book, look at the diagrams, and read the fine print. I mean, we could describe it, but seeing the illustrations in Snell's is a whole different ballgame.
Consider us the guides, but the book is the territory. Today, our mission is to deconstruct the cage that protects your most vital organs. We are going to look at the bones, the muscles between the bars, the floor, which is the diaphragm.
And then we'll circle back.
And finally, we will return to that gunshot victim to see exactly how the surgeon navigated her chest wall step by step.
So let's unpack this. We're starting with the framework, the cage itself, osteology, and right in the center we have the sternum, the breastbone.
Yep.
Now, Snell has this really vivid historical comparison for the sternum. He says it looks like a Roman gladiator's sword.
It's a great visual, isn't it? It really helps the anatomy stick. The sternum isn't just one solid bone. It's actually three parts that fuse together over time.
Right.
So if you picture that short Roman sword, the upper part, the handle, is the manubrium.
Manubrium.
Which makes sense, because manubrium literally is Latin for handle.
Okay, so we have the handle, then naturally you have the blade.
Right. The blade is the body of the sternum. In older anatomical terminology, they actually call it the gladiolus, which translates to small sword. It's the long, flat part running down the center of your chest, and then at the very bottom, you have the tip of the sword.
The xiphoid process.
Exactly. Xiphoid is Greek for sword-shaped. It's a small cartilaginous tip at the bottom that, eventually turns to bone as we get older.
So you have the handle, the blade, and the tip. But there is a specific spot where the handle meets the blade, the manubrium meets the body, that seems to be incredibly important for doctors.
Oh, absolutely. It's called the sternal angle.
Or the angle of Louis.
The angle of Louis. This is arguably the most critical landmark on the anterior chest wall.
I have to be honest, I've never really noticed a bump there on myself. Is it subtle? Or if I press on my chest right now, am I definitely going to feel it?
You should feel it. So take your finger and place it in that little notch at the base of your throat. That's the suprasternal notch.
Okay, got it.
Now, run your finger down about 2 inches. You will feel a transverse ridge, a little horizontal speed bump. That is the sternal angle. It marks the joint where the manubrium and the body have fused.
Okay, I think I can feel it.
Yeah.
It's there. But why is this speed bump so special? It's just a ridge of bone, right?
It is. But think of it as the North Star for navigation. If you are a doctor and you need to count a patient's ribs, say, to place a stethoscope for heart sounds or to insert a chest tube, you absolutely cannot start counting from the top.
Why not? Can't I just feel the first rib up by my neck?
No, and that's such a common mistake. The first rib is tucked away deep behind your collarbone, the clavicle. You can't palpate it. You can't feel it.
So you'd be guessing.
You're guessing. If you try to count from the top, you're lost.
Ah, so you'd be off by one right from the start.
Totally lost. But if you find that sternal angle, that bump, and you slide your finger directly to the right or left, you will always, without fail, land on the second costal cartilage.
That's a guarantee.
It's an anatomical guarantee. From there, you know you were at rib 2. Then you can slide down to the space below, that's the second intercostal space, then rib 3, and so on. It is your anchor.
So without the angle of Louis, you are flying blind. That is incredibly useful. But looking at our source material, this angle seems to do even more than just help with counting ribs. It seems like a major dividing line for the inside of the chest, too.
It is. It's like the equator of the thorax.
Yep.
If you were to take a laser and shoot it straight back from the sternal angle horizontally through the chest, you would hit the spine exactly between the 4th and 5th thoracic vertebrae.
T4 and T5.
Yeah.
And what does that line divide?
Well, it separates the mediastinum, which is the central compartment where the heart sits, into the superior mediastinum above and the inferior mediastinum below.
Okay.
It also marks where the trachea splits into the 2 main bronchi. It marks where the aorta arches. It's amazing how much anatomy pivots around this one little ridge.
It really is the reference point for everything. Now, speaking of the sternum, Snell mentions a procedure called a sternal puncture. That sounds honestly mildly terrifying.
It sounds worse than it is, but it is intense. The sternum is subcutaneous. It's right under the skin. And inside, unlike the long bones of your legs, which might have fatty marrow, the sternum is filled with what's called vascular cancellous bone.
Cancellous? Let's break that down.
Think of a sponge. It's bony, but it's full of little holes, and those holes are packed with red bone marrow that produces blood cells.
And it stays that way our whole lives.
It stays that way pretty much your whole life. So if a doctor needs a bone marrow sample to check for leukemia or other blood diseases, they can insert a wide-bore needle right into the sternum to suck out some of that marrow.
But you have to be extremely careful, right? Because I'm picturing what is directly behind the sternum.
The heart, specifically the right ventricle and the great vessels, they are millimeters away.
So if you slip...
If you are too aggressive, or if the bone is softer than you expect, and you pop through the posterior shell of the sternum, you are plunging that large needle directly into the heart or the aorta.
That's a fatal error.
It's a fatal error, a procedure of millimeters.
Okay, let's move from the sword in the center to the bars of the cage.
Yeah.
The ribs, we have 12 pairs. But the text categorizes them in a way I hadn't heard before. True, false, and floating.
It sounds a bit poetic, doesn't it? But it's purely structural. It's based on how they attach to the front of the cage.
So what makes a rib true?
Ribs 1 through 7 are the true ribs. They're true because they are independent. They have their own personal strip of cartilage, costal cartilage, that connects them directly to the sternum. They have a VIP entrance.
Okay, so 1 through 7 are VIPs. Then we have the false ribs.
That's ribs 8, 9, and 10. They are false because they don't reach the sternum directly. Their cartilage reaches up and grabs onto the cartilage of the rib above them.
So they sort of piggyback on each other.
They do. 10 grabs 9, 9 grabs 8, and 8 grabs 7. It forms this join rim called the costal margin. You can feel that at the bottom of your rib cage.
And then the loners, the floating ribs.
Ribs 11 and 12. They are short, small, and they have no anterior attachment at all. They just end in the muscles of the abdominal wall. Hence, floating.
Now, Snell goes into the anatomy of a typical rib. The head, the neck, the tubercle. But I want to focus on one specific feature that seems to become a recurring theme in this chapter. The costal groove.
This is vital. If you were holding a rib bone in your hand, you'd notice the top edge is smooth and rounded. It feels nice.
Right.
But the body edge, the inferior border, is sharp. And right inside that sharp bottom edge, carved out on the inside, is a channel called the costal groove.
It's like a little gutter.
Exactly. And it's not just for decoration. It houses the wiring and plumbing of the chest wall, the intercostal vein, artery, and nerve. They tuck themselves up inside that groove for protection.
We are definitely going to come back to that when we talk about where to stick needles, because knowing where that groove is can literally save a patient from permanent nerve damage.
Absolutely.
But first, let's talk about the oddball of the rib family, the first rib.
The first rib is difficult. It doesn't look like the others. It's short, it's flat, and it's broad. And as we said, it's buried deep behind the clavicle. But clinically, it is high-value real estate.
Why is it so crowded right there?
Think of the neck as a funnel. Everything going from your chest to your arm has to pass over that first rib. The subclavian artery, the main blood supply to your arm, and the brachial plexus.
Which is that huge bundle of nerves.
The massive network of nerves that controls your hand. They all drape directly over the top of the first rib.
It's a busy intersection. Which brings us to a really fascinating anomaly mentioned in the text, something called a cervical rib.
This is a great aha moment for students. It happens in about, 0.5% of humans. It's an extra rib that sprouts from the 7th cervical vertebra in the neck, right above the first thoracic rib.
A spare part. That sounds harmless enough.
You would think so, but remember how crowded that intersection is. Now imagine throwing an extra bone into the mix. It crowds the space even more.
So it's pinching things.
It can compress the lower trunk of the brachial plexus or kink the subclavian artery. This leads to something called thoracic outlet syndrome.
And what would that actually feel like for a patient? What would they complain about?
Okay, so imagine a patient walks in, maybe a young woman, complaining that every time she lifts her arm, her hand goes numb, or she has shooting pain down the inside of her forearm. Or maybe the small muscles in her hand are wasting away.
And the doctor might think it's a wrist problem, like carpal tunnel.
They might, but if they know their anatomy, they'll look at the neck. It's a mechanical problem, a bone pressing on a nerve caused by a little congenital extra rib.
It's incredible how a tiny variance in bone structure can cause such specific misery in the hand.
It really is.
Before we leave the bones, let's talk trauma. Snell mentions that rib fractures behave very differently depending on how old you are.
This is a classic pearl of clinical anatomy. If a child gets hit in the chest, say in a car accident, their ribs almost never break.
Because they are softer, more flexible.
They are incredibly elastic. In kids, the ribs are more cartilage than bone. You can compress a child's chest almost all the way to the spine, and the ribs will just bounce back.
That sounds like a superpower, but I suspect there is a downside.
The downside is massive. Because the cage doesn't break, it doesn't absorb the energy. The force is transmitted directly to the organs inside.
Oh.
So a child can have severe, life-threatening, internal crushing injuries to the heart and lungs without a single broken bone to warn you.
So a pristine chest x-ray in a kid doesn't mean they are okay.
Not at all. Whereas in adults, as we age, the cartilage calcifies, the ribs become brittle. If an adult takes that same hit, the ribs snap, usually at their weakest point, which is the angle of the rib on the side.
And if you break enough of them, you can get something called flail chest.
Flail chest is a terrifying mechanical failure. Imagine you break 3 or 4 ribs, but you break each of them in 2 places.
Okay.
Now you have a segment of the chest wall that is completely detached from the rest of the cage. It's just floating free.
And Snell describes the motion of this loose piece as paradoxical. What does that mean?
Right. So think about the physics of breathing. When you inhale, your chest expands to create negative pressure, a vacuum to suck air in. But because that loose bony segment is floating, the vacuum sucks it in while the rest of the chest moves out.
It caves in.
It caves in. And when you exhale, the pressure builds up and that loose segment blows out. It moves exactly opposite to what it should.
And that must be awful for breathing.
It destroys the efficiency of breathing and bruises the lung underneath. It's a true emergency.
That is a visceral image of why the structural integrity of this cage is so vital. Okay, so time for a check-in question for everyone listening. If you need to count ribs on a patient to place a stethoscope, where do you start your finger? If you said the clavicle, rewind. It's the sternal angle.
The angle of Louis.
Always. Great. So we have built the cage. We have the sternum and the ribs, but a cage with just bars isn't airtight. We need to seal the gaps. This brings us to the intercostal spaces, the meat of the sandwich.
After the layer cake, Snell describes passing a needle from the outside in, and you have to penetrate distinct layers. Skin, superficial fascia, deep fascia. And then you hit the muscles.
There are 3 layers of muscle here, and they are named by their depth: external, internal, and innermost. But the direction of their fibers is what we really need to visualize to understand how we breathe.
Let's visualize it. The most superficial layer is the external intercostal muscle. Its fibers run downward and forward. The classic mnemonic is to put your hands in your front pockets.
Okay, I'm doing it. Hands in front pockets, my forearms are angling down and in.
That is the direction of the external intercostals. Now, functionally, when these muscles contract, they pull the ribs up. It's like the handle of a bucket. If you lift the handle, the bucket capacity expands.
So they're for breathing in.
These are the muscles of inspiration. They open the cage.
Okay, next layer D to that is the internal intercostal.
And their fibers run the opposite way downward and backward. They are perpendicular to the external fibers.
So if I cross my arms over my chest.
Exactly. That's the angle.
Yeah.
These muscles do the opposite. They pull the ribs down. They are used for forced expiration, like when you are blowing up a balloon or coughing.
And then the deepest layer, the innermost intercostal.
This is an incomplete layer, but structurally it aligns with the internal intercostal. But what is critical, and I mean absolutely critical, is what lies between the internal and innermost muscles.
We are back to the wiring, the neurovascular bundle.
The VAN bundle. V-A-N, vein, artery, nerve.
Does the order matter?
From top to bottom.
The order is life or death for the nerve. Remember that costal groove we talked about? The gutter on the bottom of the rib.
Yeah.
The vein is at the very top, tucked deepest into that groove. The artery is in the middle. The nerve is at the bottom, often the most exposed.
So vein, artery, nerve, from top to bottom. This brings us to a common clinical procedure, the thoracentesis or pleural tap.
Well, let's say a patient has fluid in their lungs, a pleural effusion, or maybe a tension pneumothorax where air is crushing the lung. You need to stick a needle between the ribs to drain it.
Okay, you're aiming for the intercostal space. But here is the dilemma. Do you slide your needle along the bottom of the top rib or the top of the bottom rib? This is the question that saves careers. If you go just below the rib, along that bottom edge, you are aiming straight for the VAN bundle.
You're going to hit something.
You will hit the nerve, causing excruciating pain, or slice the artery, causing a hemorrhage.
That sounds like a bad day. So the rule is,
always insert the needle just above the lower rib margin, collide along the top of the rib below. That way you stay far away from the costal groove and that dangerous bundle.
ride the rib below. That's the takeaway. Now, speaking of those intercostal nerves, Snell brings up a condition that maps this anatomy perfectly on the skin. Herpes zoster?
Oh, shingles.
Yes.
Shingles. Shingles is fascinating because it reveals the hidden map of our nervous system. It's a reactivation of the chickenpox virus. The virus hides dormant in your spinal nerve root ganglia, sometimes for decades.
Just sleeping in the nerve root.
Just waiting. And when it wakes up, maybe due to stress or age, it travels down the sensory nerve fiber to the skin. Because the intercostal nerves run in these very specific horizontal bands, which we call dermatomes, the rash presents as a perfect strip.
It looks like someone drew a belt on the patient.
Exactly. A band of red, painful blisters wrapping around one side of the chest. It stops perfectly at the midline because the nerves don't cross over.
So it's a literal drawing of the anatomy.
It is essentially a drawing of the anatomy on the patient's skin.
And just to clarify, if I see a rash that wraps all the way around like a complete belt, that's probably not shingles.
Correct. Shingles is almost always unilateral. One nerve, one side.
Okay, so another check-in. You're performing a pleural tap. To avoid bleeding, do you glide your needle along the bottom of the upper rib or the top of the lower rib? Think about where the van's parked.
Ride the rib below.
Okay, we've built the walls with the ribs and muscles. Now we need the floor, the diaphragm.
The most important muscle of respiration. It's a dome-shaped septum that separates the thoracic cavity from the abdominal cavity.
Snell describes it as having a central tendon shaped like a trefoil or three leaves. Why is the center a tendon and not muscle? That seems odd for a muscle.
That's a great functional question. Think about what passes through the diaphragm. The heart sits right on top of it.
Okay.
If the center were muscle, every time it contracted, it would ball up and move significantly. By having a flat, strong tendon in the middle, it provides a stable platform for the heart to ride on.
It's a stable foundation. Now, the muscle fibers radiate out from that center to attach to the sternum, ribs, and spine.
Right. Think of it like a parachute. When the muscle contracts, it pulls that central tendon down, flattening the dome. That increases the vertical space in your chest, creating the vacuum that pulls air into your lungs.
But the diaphragm isn't a solid wall. It has to let things through.
Oh.
We have pipes running from the chest to the abdomen. So we have apertures or holes in the floor.
There are three major openings you absolutely need to know, and we use the vertebral levels as our ladder, T8, T10, and T12.
Let's walk through them, but explain why they are at these levels. Start with T8.
T8 is the cavale opening. It's the highest one. It's located right in that central tendon we just talked about. This is where the inferior vena cava comes up from the abdomen to the heart.
Why is it in the tendon?
This is pure engineering. The tendon doesn't stretch or contract. If that hole were in the red muscle, every time you took a breath, the muscle would contract and choke off your vena cava.
It would clamp down on it.
By putting it in the tendon, the hole stays open 24/7. It ensures blood flow never stops.
That is brilliant design. Okay, move down to T10.
T10 is the esophageal opening. This is for the esophagus, your food pipe, and the vagus nerves. Now, this one is in the muscle. Specifically, the right crus of the diaphragm loops around it like a sling.
Why do we want muscle around the food pipe?
Because we want a sphincter. When you take a deep breath or strain, the diaphragm contracts and pinches the esophagus shut. This prevents stomach acid from refluxing back up into the throat when intra-abdominal pressure rises.
It's a built-in anti-reflux valve.
Exactly.
So T8 is rigid to keep flow open. T10 is muscular to pinch it shut. What about T12?
The aortic opening. This is at the very bottom, against the spine. Technically, it's behind the diaphragm, not through it. It lets the aorta, the thoracic duct, and the azygos vein pass.
And why is the aorta back there not going through it?
Because the aorta is a high-pressure fire hose. You don't want the diaphragm messing with it at all. By tucking it behind the diaphragm against the rigid spine, it's protected from the movements of breathing.
So T8 vena cava in the tendon, T10 esophagus in the muscle, T12 aorta behind the diaphragm.
There's a classic memory aid for that. I ate 10 eggs at 12.
I ate T8, T10, eggs at 12, T12. I like it. Now, we think of the diaphragm as just for breathing, but Snell lists some other functions that are really surprising.
It's a powerhouse. Think about abdominal straining. When you need to use the bathroom micturition, defecation, or during childbirth, you take a deep breath, the diaphragm goes down and locks, and then you use your abs to squeeze. The diaphragm acts as the ceiling of the press.
It's also a weightlifting muscle.
Crucial for anyone who lifts heavy. When you take that breath and hold it before a squat, the Valsalva maneuver, the diaphragm, is fixing the trunk. It supports the vertebral column. It literally turns your torso into a rigid, air-filled cylinder to protect your back.
And finally, the thoraco-abdominal pump.
This helps move blood. As the diaphragm descends, it squeezes the abdominal organs like a sponge, pushing blood up the inferior vena cava toward the heart. It basically acts as a second heart for the venous system, fighting gravity.
Now, what powers this incredible machine? The phrenic nerve.
C3, 4, 5, keep the diaphragm alive. That's the rhyme you'll hear in every med school. The phrenic nerve arises from the neck cervical vertebrae 3, 4, and 5 and travels all the way down to the diaphragm.
Wait, why does a muscle in the abdomen get its nerve from the neck? That seems like a really long commute.
It's embryology. The diaphragm actually starts developing up in the neck region of the fetus and then migrates down, dragging its nerve supply with it.
And this explains that weird phenomenon called referred pain, doesn't it?
It does perfectly.
Yeah.
If you have irritation on the central part of the diaphragm, maybe from a gallstone or internal bleeding, the pain signals travel up the phrenic nerve to C3, 4, and 5 in the spine.
Okay.
But the brain is confused. It knows C3, 4, and 5 usually mean shoulder. So the patient complains of sharp pain in their shoulder tip, even though the problem is in their belly.
That is the classic trick. If a patient complains of shoulder pain, but their shoulder joint is fine, why might you want to check their diaphragm or liver? Think about the phrenic nerve roots.
Exactly. Always check the liver and gallbladder.
Let's touch on the clinical notes for the diaphragm. Hiccups. We've all had them. What are they actually?
It's a glitch. It's an involuntary spasm of the diaphragm. The muscle contracts violently, sucking air in, and milliseconds later, the glottis, your vocal cords, snaps shut.
And that's the hic sound.
The impact of the air hitting the closed cords causes the hic sound. It's usually caused by irritation of the nerve endings or, gastric issues.
And what about paralysis? If one phrenic nerve is cut, maybe by a tumor in the lung or during neck surgery, what happens?
You get paradoxical motion. Normally, the diaphragm moves down to breathe in, but if one side is paralyzed, it's just a limp sheet.
Oh.
When you inhale, the healthy side pulls down, creating suction. That suction pulls the dead, paralyzed side up into the chest.
It seesaws.
Exactly. On an x-ray, you see one side going down and the other side floating up. It severely cuts lung capacity.
Moving on to the final piece of the structural puzzle, plumbing and wiring. We need to supply blood to this cage.
The main player here is the internal thoracic artery. It runs vertically just inside the chest wall, about a finger breadth lateral to the sternum.
This artery is famous in the cardiac world, isn't it?
It is the superstar of bypass surgery. In a SAPE-G coronary artery bypass, graft surgeons will often harvest the internal thoracic artery.
How do they use it? What do they do?
They dissect it off the chest wall, clip the bottom end, swing it over like a hose, and plug it directly into the heart artery past the blockage.
And it works better than a vein from the leg.
Because it's an artery, it's built for high pressure, so it lasts much longer than using a vein graft.
But doesn't the chest wall die without its main artery?
Luckily, no. The chest wall has amazing collateral circulation. The posterior intercostal arteries coming from the aorta take over the workload. It's like closing one road, but having plenty of side streets.
Speaking of side streets, we can't ignore the lymphatics. The outline specifically mentions drainage. Why does a student need to know where the lymph flows?
This is crucial for cancer staging. The skin of the anterior chest wall drains to the anterior axillary nodes, the ones in the front of your armpit. The skin of the back drains to the posterior axillary nodes.
So for breast cancer.
Exactly. The breast sits on the thoracic wall. Understanding that drainage pathway tells you where the cancer is likely to spread first. You check the armpit, the axilla, because that's the first stop on the lymph highway.
Okay, we have the bones, the muscles, the diaphragm, and the vessels. Now, let's synthesize all of this. Let's go back to that 20-year-old woman with the gunshot wound from the intro.
Right. She's in the ER. The bullet entered the fourth left intercostal space. She is crashing. The doctor has a scalpel in hand.
Let's slow this down. I want to visualize exactly what the blade is passing through, layer by layer.
Okay. The first cut is through the skin, then the subcutaneous tissue, the yellow fat.
Then we hit muscle.
Right. Depending on exactly where the cut is, you might go through the pectoralis major or serratus anterior, the muscles that drape over the cage.
And once those are pulled back...
Once those are retracted, you are looking at the ribs. The
Yeah.
surgeon needs to go between them.
into the fourth intercostal space.
They enter the fourth intercostal space. The scalpel slices through the external intercostal muscle, the fibers part, then the internal intercostal, then the thin innermost intercostal.
The resistance changes as you go deeper.
It does. And then there is a tough fibrous layer called the endothoracic fascia. It's like the wallpaper of the chest cavity. And finally,
The parietal pleura. This is the shiny lining of the chest cavity. When you cut this, you often hear a pop or a rush of air as the seal is broken. You are now inside the pleural space.
and why did the doctor choose that specific spot? The fourth space, lateral to the sternum.
It's a calculated decision. They stayed lateral to the sternum to avoid slicing that internal thoracic artery we talked about.
Right.
And they stayed in the middle of the intercostal space to avoid the Van bundle tucked under the rib. It's the safe zone. In this case, the source text reveals the bullet had perforated the left atrium of the heart.
A catastrophic injury. But because the physician knew the map of the chest wall, they could open the cage in seconds without cutting the power lines or the fuel lines of the thorax.
That knowledge bought the patient a chance at survival.
Exactly.
It really drives home the point. Anatomy isn't just memorization, it's access. Before we close, we promised a final provocative thought. Something about the aging thorax.
This is something Snell touches on, and it affects every one of us. The chest you have at 20 is not the chest you have at 80.
We mentioned the costal cartilages earlier, that they connect the ribs to the sternum.
In youth, those cartilages are rubbery and elastic. They twist and bend when you breathe. But as we age, they ossify. They turn into solid bone.
So the cage literally becomes a rigid cage.
It stiffens. An elderly person's chest wall cannot expand and contract effectively. The bucket handle mechanism stops working.
So they have to breathe differently.
They have to rely almost entirely on their diaphragm to breathe.
So if an elderly person gets pneumonia,
It's much harder for them to clear it. They can't take that deep expanding breath to cough effectively. Combined with kyphosis, the stooping of the spine, the actual capacity of lungs decreases.
it changes everything.
It changes the mechanics of breathing entirely. It explains why respiratory diseases are so much more deadly in the elderly.
Their armor has become too stiff to move. That is a sobering thought, but a really important one for any clinician to understand. Well, we have given you the map, the metaphors, the gladiator's sword, the bucket handles, the parachute. But remember, this is just the audio guide.
You need to see the territory. Go open Snell's clinical anatomy. Look at the diagram of the brachial plexus crossing the first rib. Look at the cross-section of the intercostal space to see the Van bundle for yourself.
Reading is a lost art, but it's the only way to truly own this knowledge. Thanks for listening to this deep dive.
Keep curious and go read the book.
See you next time.